To this morning's SURSAC meeting. My name is Michelle Martinez. I am the Substance Use Recovery Services Advisory Committee Administrator here at HCA. And I just have a few disclaimers, as usual, for the group so that we're on the same page around what is being shared and all of that. So this meeting is being recorded and live streamed on TVW. The meeting will also be shared on the State v. Blake ESB 5476 webpage. So this recording is open to public disclosure. Please do not disclose any private or confidential information during the meeting. Next slide. There will be 10 minutes at the beginning of the meeting and 10 more minutes near the end of the meeting reserved for public comment. Each person will have 3 minutes to provide any feedback that you have. If you are not a committee member and would like to make a comment during a particular discussion outside of the public feedback timeframes, please just raise your hand for facilitator awareness. That would be the team's hand, especially if you're not on camera. And the public comment on that topic will be invited before moving to the next item. Feedback that is not provided during the meeting can also be submitted via email at any time to hcaesb5476@hca.wa.gov. And with that, I'll move in right into roll call. And if everyone who is not, if you haven't raised your hand to speak or want to make a comment, just go ahead and mute yourselves now. And I'll go ahead and get started with roll call. Michael Langer.
Present. Good morning.
Good morning. Amber Leaders. Senator Dingra. Senator Braun. Representative Davis. Representative Griffey. Caleb Banta Green.
Good morning.
Good morning. Don Julian Saucier.
Good morning.
Good morning. Chanel Wolf. Alexi Orr. Amber Cope.
I'm here.
Hi, Amber. Good morning. Stormy Howell.
Good morning.
Good morning. Chad Enright.
Good morning. I'm here.
Good morning. John Hayden.
Good morning.
Good morning. Nikki Lewis.
Good morning.
Good morning. Sherry Candelario. James Tillett.
Present.
Good morning, James. Christine Lynch.
Good morning.
Good morning. Sarah Gillard. Donnell Tanksley. Malika Lamont.
Present.
Good morning. Addie Adwell.
Good morning.
Good morning. Kevin Ballard.
Good morning.
Good morning. Hunter McKim.
Good morning.
Good morning. Representative Taylor. Representative Mossbrucker. All right, and we have a couple announcements as well. Michael, did you want to take these or you want me to? Oh, for some reason, is the room muted? We can't hear you.
Okay, I'm gonna test it here. Can you hear me now?
There we go.
All right. Do you want to go ahead and announce our new SURSAC administrator? Michelle, you're welcome.
Sure, and I can share the name or just announce that we've hired someone. Yep, okay. So we have hired a new SURSAC administrator, Kelly Sandaker, who will be starting on March 18th. So beginning with the April meeting, that will be the new SURSAC administrator. We're very excited to have him. And then I did have one more announcement that I had mentioned in the past that we're building a WA portal for a collaborative online hub for SURSAC, but It turns out that a SharePoint will actually be more functional for that. So we're going to build a SURSAC SharePoint site, and I'll let you know as soon as that is up and ready for folks to begin, contributing to that hub. So that's all I had for announcements. Was there anything else?
Well, I do want to make sure to welcome everybody to the meeting here today. In Olympia land, it is 4 days of session left as we pay attention to bills that are moving their way through the legislature, as well as the budget. And while the news on the opioid overdose, particularly fatal opioid overdose, it's still challenging lots of folks, right? A lot of people, a lot of families, most communities are still impacted in a really high level. There is continued recognition of this and support coming from the legislature. So we see that the governor's call outs to address the issues of behavioral health and substance use, in particular for this group, were again appreciated. It came out in his budget in December. Both the House and Senate version of their budgets were also supportive of additional investments. And then in addition to that, there's state funds and so forth. We have the opioid settlement fund. So we are looking forward to seeing how that sorts this week. And we'll make sure that we communicate that with you once we have that information. So again, welcome. I know we have a full agenda here today, and I just appreciate you guys continue to show up and into this work. And please, throughout the day, ask the questions that you have, or appropriately give your feedback into this work. So thank you all, and I will go ahead and turn it over to Blake, I believe, at this point for our first set of good Monday. Thank you.
All right, thank you, Michael. Good morning, folks. Now it's time for public comment. If any member of the public would like to make a comment, go ahead and raise your hand in using the raise your hand. As you see, I've got mine up there. If anybody's got a comment, again, please raise your hand virtually. Doesn't look like we have any hands. Again, time for public comments. If you would like to make a comment, please go ahead and raise your hand. Okay, we'll take it that we don't have any public comments this morning, so we will close that out. How about walk-on items as the next topic on the agenda? Is there anything that we need to, these would be items that we could get to quickly at the end of the meeting? Anything that we want to add? Anybody have a topic that would fit that bill and give us an opportunity to talk about it towards the end of the meeting? Any new topics? Hey, Caleb, what do you got?
Good morning. I'm actually trying not to follow the legislature very closely, but it would be helpful to have some discussion. I don't know what the status is of the child welfare fentanyl law, where that is, because it, from my perspective, doesn't have any evidence base to it. So I'd love to have some conversation, understand where that is.
Okay. Will we be prepared to do that on the HCA side?
We will look up the status of it, Blake, and report back at the end. So.
All right. All right. Thank you, Caleb. Appreciate it. Thank you, Michael. All right. And we have meeting guests. Not sure who that is, but you got your hand raised.
Sorry.
It may
have
be
a-
me. This is Malika.
Oh, yeah.
But
Hey, Malika.
hi, can you see me as a person? Because it says I'm on there, but I don't know.
See you as meeting guest, but that's all right. I hear you.
That's weird. Okay, so Caleb, to answer your question about 6109, it has continued to move forward, and it went to the House. The last we heard, they were removing the fentanyl test strips as a basis to remove children from the home. However, it's still, to your point, not going to keep children. It's not evidence-based. And it continues to not be evidence-based, but it still has legs, and it's gonna be something. Like that's they're going to, they have put the language that the presence of fentanyl in the home is on par with sexual abuse, as well as physical harm, sexual exploitation, or neglect. So they're changing the statute. And that part did not change.
Okay, thank you for letting me know. And hopefully we can get to the point where that actually be an opportunity to bring services into the home that are evidence-based.
Well, the services that they want to bring in the home would be pilot programs that have one-time funding.
Thank you. If we have more time at the end, maybe we can dig into it a bit. That'd be great. Thank you.
Thank you, Malika. Anybody else have items that they'd like to put on the agenda?
Yeah,
for discussion.
if you can hear me, Blake.
Yep.
To Caleb's last point here, if we do get time, we can look in, get the official standing and so forth. The other option, an additional option, would be to ask DCYF in the future to come in to share how implementation would go and things of that nature. They did a pretty nice presentation with us in a recent state opioid leadership meeting that maybe this group would be interested in after that.
Okay, thank you. Anything else? Okay, I see one hand up. Malika, I think that maybe still be yours as meeting guest. Any comments?
It's not me.
It's not you? That's odd. Okay. All right, so let's go ahead and then move on to our RNP report dashboard review with Ryan and Brianna.
I'm sorry, pulling up the slides now. I know we sent them a little bit late, so I apologize. But we are covering 2 quarters in this to play a little bit of catch up. Hi and welcome. We'll be covering quarter 3 and quarter 4 of the calendar year 2023. Covers July through December of last year. So this presentation will cover updates on the report in the dashboard, referral and outreach data.
Brianna, people are saying it's hard to hear. You can just speak up a little bit.
Okay, sorry. We'll be covering updates on the report and dashboard, referral and outreach data, case management data, and success stories from our friends in Spokane. We are collaborating with the data group to update and publish the public dashboard. We expect to have, you can go back. It's okay. We expect to have something to present when we do the quarter 1 data report on June. At a minimum, we hope to provide the regional data that has not been included in these last few presentations. Michelle had sent out an annual timeline for the meetings, and I have posted on here the tentative schedule and what quarters will be reporting out at those meetings. So the one thing that I really want to know first and foremost is the estimated unduplicated clients. This was the feedback that we received from this group, and we have gone and found some unique ways to gather or get close to unduplicated clients by using a variety of different personal identification items that we have available in the workbooks. And we will continue to work on improving the accuracy of the unduplicated clients. According to the data,
there were 6,582 outreach encounters, totaling the 3,197 unique clients. Keep in mind that it may require multiple outreach encounters before a person accepts services, gets enrolled into case management at whichever level they want. Therefore, the average ratio of encounters to referrals may be about 2 to 1, but that's also not the case for everybody. Sorry.
Brianna, if I could interject here, Stormy, did you have a question? Stormy?
No, I do not.
Okay.
Oh, I don't know why my hand is up. Sorry about that.
Okay, no worries. I thought maybe there's something going on there we need to address, but sorry to interrupt.
I also wanted to cover the law enforcement referrals. This includes both social and diversion law enforcement contacts. We understand that these are two distinct contacts between law enforcement and individuals. Social contacts occur when law enforcement initiates a contact with an individual during either their rounds or when they're called by individuals, their families, or businesses. During social contacts, law enforcement officers often make referrals to the Recovery Navigator without making an arrest or issuing a citation. On the other hand, diversion referrals occur when law enforcement encounter individuals who are believed to have committed a minor offense, who can be safely diverted from the criminal justice system. And that makes up 12% of the referrals that we received in the Q3. I also wanted to kind of go through some of the top referral reasons. Considering the RNP data collection workbooks currently have a drop-down selection, so that allows for multiple options to be placed under a single encounter for items such as direct care services and referrals of services made. All of this feature is helpful for capturing the many resources available to the individual. It also poses some issues in ingesting and reporting this information. We will review the issue and discuss how to present the data with the data team. We also plan to improve data collection when we start moving towards the data integration program. What I was trying to really avoid is having we developed the drop-down option of multiple services provided, and it didn't really give us a clear picture of what that was provided. So we're kind of working with the data team to see how best we can demonstrate what services were provided. The only thing is that it might not be on an individual level. It's just how many of those were provided through all their encounters instead of how many were provided, for individuals. So we are working on that, and we are continuing to improve this presentation and the dashboard. I would also like to draw your attention to the response time, which shows that 81% of referrals received a response within 15 minutes. We believe this reflects the dedication of our field teams and their ability to successfully engage with community partners. Of the number of referrals from the previous slide in referral and outreach, 223 were enrolled in intensive case management and 574 were enrolled in light case management, which leaves others in the outreach status. Outreach coordinators will continue to build relationships until the individual is actively enrolled and converted into light case management or intensive case management over time. I wanted to touch a little bit on what intensive case management and light case management. Light case management is when an individual is interested in basic services, such as housing. The individual is considered a program participant, while intensive case management means an individual has comorbidities and needs more services and might be experiencing homelessness. I want to really quickly go over the race data. This is based off of the individuals, so these percentages are based off of the 3,197. I don't have ethnicity on here. I'm running out of space, so I really apologize, but I will say that 263 of the outreach referrals do identify or self-reported as Hispanic. I think viewing the demographic data here in referral and outreach is really interesting. The primary challenge faced by providers during this stage is gathering complete data. Due to the sensitive nature of information collected, individuals may be hesitant to share their personal details with providers. For example, referral and outreach indicates there's a substantial number of unknown in the demographic data, as you can see here in that lighter orange color. It is essential to understand that this stage is crucial to the success of the overall process. Once a relationship is established between the provider and the individual, it becomes easier to gather accurate data, develop a personalized plan, and connect to the necessary services. I will demonstrate later in the presentation what that looks like side by side. Our future plans involve collaborating with RDA to compare RNP population to a comparative group based on specific criteria related to individuals with criminal activity related to substance use. We have made a slight update to contingency management, as you can see here. Though it reports that way in the workbook, we understand that some don't use it in the therapeutic sense. So we've made the update in this presentation to show that it's a contingency management style encounter. We know that what they're using it for doesn't fully align with the clinical usage. While there are a few providers who do offer the clinical contingency management services, most of the time it's used to represent small tokens that encourage engagement and build rapport. We're still using the term to tie it back to the usage in the workbook, but we want to be clear that it does not always represent true contingency management in these reports. I'll take a moment so you guys can look at this slide. The top services that were provided, the top services made, and the estimated unduplicated clients in case management. That's slide 7 or 8.
I just want to real quick bring attention to a question. If you don't want to stop your flow, we can come back to it. But Hunter was asking, how can one get involved in RNP fieldwork to increase these numbers in 2024?
I will defer to Ryan on that one.
Yeah, so I can speak a little bit to that. The RNP fieldwork is done by the Recovery Navigator providers that are operating across the state. So this is an aspect that is part of their jobs. I don't know that we have an official volunteer policy for that, but individual providers may be in a position to work with others in their community to do some outreach. So really, I would encourage you to contact those that are operating in your county to discuss if they're doing events or situations where they might be able to do that. There are some potential liability concerns that we want to make sure it's not something that is just open to everybody. We have some safety standards and some things in our existing program standards that would address that. But certainly your local provider on the ground would be in the best position to respond to that.
Ryan, can we send out the list of providers by county?
Yeah, let me post that here. That link is up on the State v. Blake page. So I'm going to put a link in the chat here to the list of providers by county.
Thank you.
Is there any other questions? I do want to talk a little bit about as I had stated previously, there was 223 clients that were enrolled in intensive case management and 574 in light case management. But the case management shows over nearly 2,000 individual clients. The case management team is responsible for providing long-term support and assistance to those clients who are in case management status. This means that their cases require ongoing attention and support, sometimes extending over several months or even years. The case management team works closely with these clients to develop and implement personalized care plans that address their specific needs and goals. The level of referral, outreach, and case management provided by Recovery Navigator programs varies across different regions. However, it has been observed that most of these programs are currently operating at or near their capacity. This issue has been noticed in several diversion programs across the state, indicating a growing need for increased resources to support these programs. I think. Yeah. So this is covering quarter 4 data. Here the response time is a little bit lower. Enforcement is a little bit lower, and the unduplicated clients is a little bit lower. Again, that kind of goes back to what I was saying, is that some of these are operating at or near capacity. So there's, as much as we try to respond to every referral, their caseloads are growing very, very quickly, and they're requiring more and more support. There could also be possibly the weather, again, with quarter 4, the rain and the snow, especially in some regions, having to travel to some of those areas. There's a lot of variables in there, but there's a overarching that they do need more resources to provide to these programs.
Brianna, I think it may be worth noting here, I'm trying to look up the number, but I believe it's a House budget that has some additional resources for Recovery Navigator counties, recognizing they're hearing that there are some that are at capacity. It doesn't say where the dollars go, just that it has to be going to those counties that are at or near capacity and they're running out of money, basically. Some are still working on sort of carryover funds from that first year of startup. So we'll know more again when the budget's out, but there is some recognition and some additional resources.
And here's the demographic data for quarter 4. The Hispanic population made up 196 of the outreach and referral encounters. A little bit quicker. I know I talked a lot in the first part, so because we're presenting 2 quarters, a little quieter for this second part, but I do have a few things that I want to highlight. There's many of the top direct services and referrals align with the previous quarter, and the peer support transportation services increased this quarter as well. Anybody have any questions or comments at this point?
Yeah, so Brianna, I'll point out there was a question in the chat asking to explain why the number of 1,954 and how that was different than the enrolled in light or intensive case management from the prior slide. And that's something that as we go through these slides, we want to make sure that some of them are referring to the data that's captured on referral and outreach, and then others are referring to case management. So the numbers are going to represent different stages of where folks are at. I know I put an answer in the chat, but I just want to make sure to follow up and make sure that's clear. But if there are any further questions on that transition, feel free to put them in the chat and we'll respond as we can.
Thank you, Ryan. The next slide, and I really want to, I did this comparison of the side-by-side of what it looks like, the demographic data from quarter 4, from referral and outreach to case management. This slide was created with feedback from this group. We are really excited to share this with you. The slide displays a side-by-side comparison of demographic data from referrals and outreach and those who entered in case management. It not only shows numbers and percentages, but also highlights the relationships that are established when an individual enters case management. This is a testament to the hard work and dedication of the providers who make a difference in people's daily lives. Notably, the percentage of unknown cases has decreased significantly from 43% in referral and outreach, 4% in case management. So this was huge. This was something that we had talked about at previous meetings. And so I'm really excited to actually see it come to life, seeing these side by side and seeing that the relationships that were built from one to the other. And it's super important, and I'm super proud of the providers and the ASOs for all their hard work to do this, to build those relationships. Amazing job, amazing job. Talking about our amazing providers, we have the Spokane BHASO with us today. And
sorry, Brianna, to interrupt. Is there time for one question? We've got Caleb's got his hand up.
Hi, just trying to make sure I understand this. So you're saying the referral and outreach is 42% white and the case management is 64% white. Is that correct?
Correct.
And it's very hard, obviously, with this much unknown to know what's happening. It's very, very hard. That seems disproportionate. It seems like you get more complete race data on the case management side. So I could imagine this could just be more complete data, but it would be really important from an equity perspective to figure out, to really dig into this and understand what's happening. Because this looks bad. I think it's probably actually a data reporting issue with the unknown being better known under case management. But if there's a way to also reverse engineer from case management, look back at the referral and understand what that unknown looks like and how they're reported there, that'd be really helpful to understand from an equity perspective what's happening here. Has that been done, or is that something that could be done?
That's something that we were looking into. We've had that internal discussion, and so we're looking into how we can reverse engineer this information. But it's going to take us time. We're still, working through with the data team on how to get everything up to par with the estimated unduplicated and such. But we are having those conversations. So I will.
Okay. It seems like okay. It seems like an obviously place to start would just be look at the people who are identified as white in case management and see how they were coded in referral and outreach. And I see Amber has something also in there. I know she's in the midst of this.
Yeah, if you guys don't mind, real quick, I was just gonna say that when outreach is performed, we don't gather as in-depth demographic data as the case managers do, or people may not be willing to share all that kind of information because they're in crisis. We're basically triaging. And so what she's trying to show here is that relationship that case managers build with people, that trust that case managers are building with people. That's how we're able to gather that demographic data in a more complete way once people are moved to case management. Does that make sense? I don't think it's a failing on anyone's part. I think it's natural that when people first meet somebody in the street, they're going to not want to share as much of their, they're not going to want to answer a bunch of demographic questions as opposed to, how can you help me right now? Ease my suffering right now. Meet me where I'm at right now. So
I totally get data collection and prioritization in the field. I totally get that. It's worth looking at because this appears bad. It's probably not as bad as it looks. It may not be bad at all, but it's an important thing to look at in terms of access. And in fact, given a population of the state, this may be a reasonable mix on case management. It would just be helpful to know that.
Caleb, do you think it's significant at all to note that the percentages from referral and outreach to case management for the non-white population doesn't seem to be decreasing, even though the white population appears to be more accounted for there?
Yeah, well,
maybe
I love
one does.
pie charts. I don't want to overinterpret them. So you really need to dig into it. And it's not complicated to do just a little bit of crosswalking of those two data sources, but it's really important from an equity perspective, right?
Yeah.
Working really closely with the data team, and hopefully I'll at least have an update for the June meeting for you, Caleb.
I also want to say this isn't just for outreach, it's referrals also, and people making referrals may be members of the community that have no idea about somebody's demographic information. So we can be entering these referrals in, and that demographic information isn't known because outreach hasn't been performed yet. So you have to look at it from that perspective as well.
So this is Malika, and I can't raise my hand for some reason. Sorry, Blake.
No worries.
Go
for it.
But I mean, instead of continuing, like, I feel like from the very beginning, we have continued to make excuses about why there isn't, I'm just going to say it, good data. And I really hope that folks will listen to what Caleb is suggesting about ways to get better. And I know that as the director of the Lead Support Bureau, we have given lots of support around how to better engage with folks in order to get at that information. And as a person who has been a crisis response worker in the field and also a case manager, it is possible to do that. And I'm just to get accurate information from folks, even when they're in trying circumstances. So I'm really hoping that we can, reach one of the goals that is the lead model, that we can start to address the disparity of folks that are being entangled in the criminal legal system, the racial disparity. That is part of why that model was developed. And it's relevant across the whole state, even though I understand Washington State is a very, has a lot of white people. So I'm just hoping that we can maybe Caleb can work with HCA to really get on that data crosswalk.
And I'm also hoping that when we break it down by region, it'll really help us find those target areas as well. So there's a lot going on in the background. So hopefully in June we'll have better data models to show and can have a lot more discussion surrounding that. But yeah, thank you, Caleb and Malika. I appreciate your comments. I will review that ask with the data team and provide you an update in June. Are there any other questions?
Think we're good? Some in the chat. All right, Brianna, we ready for the next item?
So
Thank you.
Is Pioneer Human Services on the line?
Yeah, we are.
Yes.
Hi. Thank you for coming.
Thank you for having us. My name is Darren Christensen. I work here in Spokane with Pioneer Human Services. We implement the program here in Spokane County. Today, to share a little bit of a story of someone who's been involved in the program. Now come in a fairly unique way. We've asked Sarah Devaney to be with us, and she is going to share a little bit of her story. And then afterwards, I think we've been asked to share a little bit about some of the nuances of things that have been working and challenges that we've had in our program here locally. So with that, I'm just going to invite Sarah to take her mic off mute and just talk a little bit about her story.
Hi, everybody. I'm Sarah, and a little my backstory. I was raised in for what the most part a normal family. In my family, we were surrounded by alcoholics and drug addicts. In my immediate family was, the normal family in our unit. And so I grew up not really around the conflict of having addict parents or immediate interaction with that. I went to school to be an LPN and worked as a certified medical assistant for 17 years. And in the midst of my son falling with diabetes and my kid's dad passed away, life just started kind of happening and I fell into my addiction at that time. I had made friends with somebody I probably shouldn't have and ended up with a court case that was pretty severe and I was looking at a lot of time in prison. I ran from it for a long time and decided I went over to Seattle in Tacoma area, was running pretty hard in that life. Ended up coming back to Spokane to try to deal with the situation and went to jail for significant amount of time and was given the opportunity to be on the FOSA program. I went to treatment, and after treatment, I decided to live in an Oxford house while I was on probation. While I was in that stage of my recovery, I got hooked up with the Recovery Navigator Program and attended their the Roadmap to Success class here through Pioneer. And, after being a nurse for so long and then getting felonies, I was in a state where I didn't know what I was going to do with my life. A lot of fear that I was not going to be able to support for my family or what direction I was even going to go from there. And the Roadmap to Success in the RNP program really helped give me encouragement and direction to that there was other options to explore as far as getting, stability back into my life while in recovery. I graduated the Roadmap to Success class and decided to get my certified peer support thing going on here. And now, after being in recovery for going on 3 years now, I'm able to be a part of the team and help the people that are out there struggling, going through some things, that I have some understanding and compassion about, and being able to reach people, I think, in a different way, having that life experience and understanding to where I'm in a place now where I have that hope and stability, because I give a lot of credit to the program that was able to help direct me and support me through that time in my life. So here I am. I don't know where else to go.
So to clarify, Sarah is currently working as one of the peer navigators on the recovery navigation team here in Spokane, and is doing an excellent job, and really a strong advocate for those in need, and is obviously shares her personal passion with the way we implement this work. And I guess that's a good transition into kind of some of the things that work for the program here in Spokane. We interact with a lot of people here quarterly. When you break down regional numbers, I think in the future, I don't know how much they share that here, but we're seeing a large percentage of people that are being supported through these programs across the state or right here in Spokane County. And that has to do, and I think first and foremost, with the passion that the actual members of our team have. Their dedication to this work comes from experiences that are very personal and drive them every day. And I know that that's what has led to success for us. Some other things that I would note that have been really important for us to do well here have been partnerships. And I mentioned that in two ways. One, in the sense that we're not the only people with this idea or effort that are trying to make impact in people's lives here in Spokane. And because we have these partnerships, sometimes internal with different programs here at Pioneer Human Services and sometimes with other agencies, it has become very beneficial to know that map of the land, to just know who all the players are here, what they can do, where they can do it. And it has become sort of the tool for our navigators to really be successful, is constantly having this updated level of information of what's available and who's doing what and where they're doing it. It is allowed here in Spokane through some coalition work to be a little bit more strategic rather than multiple random agencies just doing their best to reach out, but rather than those efforts have become much more coordinated, clear down to actual individuals coordinating services for multi-agencies around one person. That has made real impact and led to some success. The other thing that has to do with partnerships is, as much as the members of our team are doing outreach and they're locating individuals, or receiving referrals, or following up on referrals, or assisting individuals, everybody on our team to some extent is setting aside time to learn. And what I mean by that is to learn how the lay of the land is changing. When funding has maybe pulled back in one area and it showed up in another area, being aware of that change, being aware of changes in the dynamics of the shelter systems as that changes across the year, being aware of new opportunities for new detox programs, for detox programs that are maybe overwhelmed and not able to function in the way they like, so that they constantly are on top of what's needed and what their tool belt looks like every day. Making sure as a team that we look at that and are emphasizing that piece for everybody, that anyone's input into that is helpful, has been great. One of the exercises that we took on early on is there wasn't a comprehensive listing of every, in one place, I should say, of every provider for inpatient, detox, mental health, co-occurring. It just didn't exist, with the nuances of what days can you go in there and get an assessment without an appointment? What days are they available? How many beds are available? What are their funding streams? And so we took a good chunk of time early on and put that together as a collective, as a map that people could reflect on and look at. Now, it doesn't work 100% because things change so quickly. Literally being able to know every morning where available beds are at is a real key for those navigators. But taking the time to make that effort on the team, everybody on the team having, the flexibility to say your input onto this is valuable, please take the time to do that, has made a big difference. When I move over to some of the things that we found challenging, I think some of them are probably fairly common to other providers. One of the things is just the lack of appropriate SUD services for the timing of when a client needs it. There's never enough detox beds. Particularly, there's never enough inpatient beds for women in our community. Those things have been huge barriers, and which is why knowing exactly what's available every day has become a real challenge. I know that there are efforts being made to increase the availability and access to those here in Spokane. It is difficult when the need is so high, and then you're learning about all of the barriers that those providers are running into to get more beds up and going. Anyway, you can understand the frustration that comes with that. Some of the other things that I think are a challenge are the moving resources. It's tied to this, to what I've mentioned, has become this need for our team to always be learning and knowing the resources out there, is that everything's constantly moving, and that's always a challenge. Who has availability, which programs can take people on, which programs have changed policy for who they will and won't serve. All of that is never something you can set and depend on. You're constantly trying to find your way around that. I think one of the other things that has become, it's interesting, I guess it's a little bit of a catch-22, and that's working directly with our law enforcement team. So unique to Spokane, as with other larger urban environments, so we have dedicated parts of the law enforcement community that are specifically for behavioral health outreach. And those individuals are the ones that we partner with the most. And that's because most of the law enforcement officers depend on those individuals for situations to respond to that would fall into the dynamics of the Recovery Navigation Program. And unfortunately, that has less and less officers outside of that specified group who reach out. We'd like to see that change, but that is sort of a cultural change that I think is going to take more time. But within that group of very dedicated law enforcement individuals, they're reaching out, they're using their resources, and we're partnering with them. That has been of great value. And then I think that, yeah, I think those are kind of some of the things that come to mind for us as the things that have led to us being able to reach out and connect with so many people, and being just open to not be territorial at all for what other organizations need. If they only need one little piece of our effort, then we'll give that little piece rather than assuming that we need to take on the whole aspect of this individual's life. And that has also been very, very successful. That leads to a lot of trust in amongst the agencies, and we kind of get over some of those barriers, and then we're able to access and support more people. I don't know, is there questions? I guess we can open it up to that if that's appropriate at this time that people might have. We'd love to share anything that you might be inquisitive about.
I'll jump in here.
Sure.
Thank you, Darren. Thank you, Sarah, so much for sharing today. I have lots of questions, so a couple I'll throw out there. One is, as the trust is built in the community, Sarah, I'm assuming you're getting more and more referrals or more people that want to talk to you. Can you say a little bit about the capacity in the city of Spokane to sort of meet the need, maybe way to go? I also have a question, if you weren't there right now, what your perspective would be of what would these individuals be doing? So just talk a little bit about the story of capacity. And then it may not be fair to you because it may be another provider or something in Spokane, but are there any calls coming outside of the city, out in the outlying communities, and are you able to address any of those? So there's a few questions.
Sarah, if you want to take the first, then I can respond to the second part.
Okay. The first part was
About capacity, our capacity need.
yeah. So being, having the understanding and having that life experience to be able to understand and connect and relate to these people, and understanding a little bit about what direction they might need to be going as far as having connections with, for anywhere from the detox to the inpatient, all the way down to wherever they're trying to get in life, having those connections and understanding maybe the barriers that they may be facing, having the resources to help them navigate through that is a huge part of having that connection with not only with our program, but with the clients as well. I think.
Sarah, as you help people, as you're having the ability to help people navigate that, are they sharing are they sharing your name with others so you're getting more and more people?
Oh, absolutely. Yes. I'm finding that's happening quite a bit, which I appreciate, that my story and that being able to help guide some of these people is building such a trust in our community, that letting them know out there that there's people who, you can go to. And I get calls all the time on the weekends at night. For instance, last night I got a call from somebody who had got my name from somebody else in the community who was needing to get some help. And that just shows that, there's that trust is being spread throughout our community. And I think it, not just for myself, but for a lot of people, everybody on our team has that experience.
Yeah, that's interesting. I think that when you talk about one of the things that's led to the success is some intentionality about reputation. We've really tried in a couple of different ways One has been our response time. So when you look and monitor that response time, we've been very aware of that, to one, be consistent, and also to be as quick as we can. And that has led, I think, in many ways to, and it also has to do with some values in our company about really walking the talk. That's something that as a company we really try to do, not make promises that can't be kept. That's led to a reputation where people are feeling like, oh, those guys are safe, particularly in situations, where we show up and we're showing up there with law enforcement, and law enforcement's led us there. There's some trust issues that those individuals may have with law enforcement. Then how do you suddenly not drop that association that they have with us? And I think that's come because of track record of what people have experienced for the way we provided services and offered things to them. That's led to some pretty positive outcomes. Capacity wise, we've looked at sort of the dynamic of how we've made up our team, and we've made some adjustments. Like what we realized as we looked at it, although we are making the effort to try to increase the number of individuals that get into more complex case management as much as possible, we know that wraparound service is more value, but we realized that in order for us to get to more people, that we needed to shift, and we needed to add a couple more people in a navigator situation rather than this deep case management. And so changing those resources has allowed us to meet more of the need, but we're not meeting all the need. As much as our statistics look like, wow, you're talking a lot of people, there's no way we're getting close. One of the things that'll happen is, let's say we've got a follow-up appointment with someone and we go to a shelter to meet with that person for this follow-up appointment. That staff member, before they leave that shelter, may have 4 or 5 new referrals before they leave the door. And so that kind of stacks, which means you get to a point where like, hey, when's the last time we did street outreach? Oh my gosh, I haven't done street outreach in 2 weeks because I'm constantly following up and doing what's right in front of my face. Yeah, we're not there yet. Every quarter our numbers increase, the number of people we're seeing. So we don't know yet what the sweet spot is for the number of people we have on the team. And maybe we'll learn that in the next, couple more quarters and kind of find where that's at to know, oh, this kind of is where we max for our numbers. So as much as we've been doing it, as long as we have, our numbers have just gone up and up and up and up every quarter. So there's more to be learned, I think, in that area. The other question that came up, and that has to do with people in the more rural areas. So we're tasked with working in the entire county. But a unique thing to Spokane is clearly we have more services than in our surrounding counties. So in our regional group, we've set up some pretty unique relationships of inter-county referrals, where the smaller outlying counties who have far less resources regularly are referring into our team members. Some of the handoffs are just like, they'll bring someone down and that individual might be in a shelter for a couple of days while they're waiting for a bed for treatment. And as soon as they're down here, then they're handing off and we're checking in on to make sure the person has support to make sure they can follow through with what they want. Sometimes it's been much more direct. It's been, you drive 50 miles, we'll drive 50 miles, we'll switch them in the car and then we'll drive back the rest of the way. I mean, that's happened multiple times, and not just neighboring counties. Regionally, it's extended out across different communities across Eastern Washington. Just real partnerships to help be willing to serve people and not say, oh, well, that's not our person. And in effect, be able to serve in ways that I think have not been allotted to some of the more rural communities at all in the past because of the lack of services. Like, how do you overcome that? Don't have detox, you don't have inpatient in your county. How do you get them somewhere where it's at easily? And I think this system of interaction between different RNP programs has absolutely created a way to break through that type of a barrier to serve others. Did I answer your question a little bit, Mike?
Yeah. Thank you both. I mean, it's very interesting to hear how you're making it work. Really appreciate it.
I really feel the trust that's being built, not just with our participants, but that's being, like Darren was saying, it leads through the behavioral health unit, our law enforcement, to other community resources, to other counties. That trust has really been built, through all of that, through word of mouth as well.
All right, any more questions?
I don't have a question. This is Malika. Sorry, and I can't raise my hand because it doesn't
Go for
work.
it.
But I just wanted to give you all a compliment that for demonstrating, the potential of what RNP can be with like weaving together a safety net across Eastern Washington and working together in collaboration and really building those relationships. So I just want to say kudos.
Thank you. All right, thank you so much for being here. Appreciate this visit.
Thank you, everyone.
Next, thank you. Next on our agenda, naloxone and overdose prevention educational campaigns. And I believe that's Chantel, Melissa, and Ann.
Everyone,
Whenever
I
you're
guess
ready.
I can go first. Let me figure out how to share my screen quick. Bear with me. Okay. Hopefully everyone can see my screen. My name is Chantel Wong. I'm with the Washington State Department of Health. If you can't see my screen for whatever reason, please drop it into the chat or let me know as soon as you're able. But thank you for having me here today. I'll be giving a brief overview of our summer 2023 campaign, Prevent Overdose WA, which was an opioid and fentanyl overdose prevention campaign.
I can't see. Oh, there it is. Thanks.
Okay. So for our campaign, we had a couple of different things going on where for the DOH or the Department of Health's campaign development process, we try to at least go through 6 phases of research to help inform our campaign messaging and our strategy. This sometimes, again, cannot always be done just because there's going to be constraints with timeline, budget, other external things going on. But for our campaign, we are extremely happy that we were able to go through all 6 phases. So for our campaign development process, we always start with doing some secondary research. So doing kind of a landscape analysis, seeing what other campaigns have been done on this topic, what they found to be helpful, looking for kind of knowledge gaps or niches that we can use, as well as best practices in this field. For our second phase of research, we conduct partner interviews. So we wanted to get partner feedback to help inform our campaign focus, messaging, and strategies. So we really look to people who work in the field, such as medical professionals, social workers, people with lived experience, that type of thing to help inform our campaign focus and messaging. Our next stage, we were able to have focus and message testing because we really wanted to understand awareness, barriers, and motivators to harm reduction behaviors. And I'm not sure if anyone has a background in social marketing, but one of the goals of social marketing is to enact a positive behavior change in communities and individuals. So we really needed to see what could be done from a social marketing standpoint as far as pushing certain behaviors for individuals and communities to do that is feasible for people, but also is feasible from a social marketing standpoint, because of course, campaigns can't do it all. There are some restraints to what we're actually able to help enact. With the focus messaging testing and our concept testing, we were able to look into people who had lived experience, so people who are using opioids and their care networks to help kind of inform that work. So we tested our messaging, tested our brand to see what resonated as best it could, because those are the people that we're trying to reach. And then finally, we had 2 different sets of surveys that went out for our campaign development. We always start off with kind of a baseline awareness survey before any campaign goes into the field. So any materials like videos, ads, things like that, before any of that get created, we wanted to see, do people have general knowledge on this topic? Do they know what things like naloxone is, how to use it, how to get it? What are they struggling with as far as barriers and motivators to carrying naloxone or not using substances alone? So it gives us a really good understanding of what we might have to overcome or what we could overcome within our campaign. And then finally, we have an ad recall and awareness survey. So after the campaign is all said and done, after everything is pulled from the field, so no more ads are going out, things like that, we want to do one last survey to see, do people remember our campaign? Do they feel maybe more comfortable learning about the topic or sitting with the topic, or having that knowledge and education to know things like where to get naloxone or how to use it? Basically, what was the effectiveness of our overall campaign strategy? And were we actually able to reach the people who need the help the most? So that's kind of some background into how our research informed our campaign development. And I want to go into next some of the behaviors that we were able to promote and then who our priority audiences were. So for behavior focus, based off all of the research that we have done through those 6 phases, we had 2 main behaviors that really stood out, mostly because that they had strong motivators and they were, again, feasible for individuals to do and also feasible from a social marketing standpoint. So our 2 behaviors that we were able to promote was carrying naloxone, specifically for someone that you love or care about. And then our secondary messaging was not using substances alone. These resonated really well with people who have lived experience with substance use, and it also really resonated well with the care networks who are part of our priority audiences. So for our priority audiences, for the people who use opioids, a lot of them found that they knew about naloxone, but they didn't really necessarily feel the need to carry it, or they didn't feel comfortable administering it. And then for the care networks, these were people who were kind of on second tier from people who are using the substances. So it could be family, it could be friends, it could be anyone that you work with, someone that you know and love, kind of second removed. And they felt also that they weren't really sure why they would need to carry it, but they felt a really big motivator to carry it because they wanted to have it just in case they needed it to use for someone that they love or care about. And then finally, we have some audience overlays. So we looked at the populations who have been disproportionately affected by opioid overdose. And the research that we did in our secondary research came to the conclusion that our campaign needed to focus on people who identify as male, young adults ages 16 through 24, people who identify as Latino, Hispanic, Black, African American. And then additionally, we wanted to recognize that there were 13 counties in Washington state that had higher overdose rates. So we wanted to give those counties a little bit of extra love and care with extra advertising materials such as billboards, things like that. So here are some of our campaign assets that were put in the field. So this campaign was only in the field for a little over a month. So it launched, I believe, on May 29th of 2023, and then ended end of June of 2023. So we were able to do a lot in that time, surprisingly. But we had ads that were on digital and cable television. We had a microsite. We had social media platforms, Instagram, Facebook, TikTok. We also had radio advertisements and billboards, and all of these were available in both English and Spanish. So here's some good examples if you ever want to tag through. I did link, if the slide decks can go out, I'm happy to link the English and the Spanish videos for whoever's interested. And then finally, here are some of the results for this campaign. So again, this campaign was only in the field for a relatively short amount of time. It was barely over a month, but some of the results that we were able to see were honestly, in my opinion, just incredible. So in terms of awareness and behavior results, we saw a 98% increase in naloxone orders from stopoverdose.org in the 13 focus counties that we were trying to reach. And then statewide, we found to have an increase of 14% overall for naloxone awareness. Campaign engagement, we had some pretty high numbers for social media, completed video views, website visits, things like that. And then the last thing I really want to focus on was our ad recall. So again, this is the survey at the very end of the campaign, once all the advertisements are kind of pulled back because it's the end of the time period for the funding. But we looked at ad recall of who remembered the ads, who felt comfortable learning about the ads, and then looking at how they felt about everything overall. So looking at people who use opioids, Spanish speakers, care networks, the BIPOC communities, and then the general population, the ad recall was the highest amongst priority audience groups. So we really were able to reach the people who we were trying to reach. And we know that our materials really resonated well because they kept going back. So in my opinion, the results for a campaign that was in the field for 1 month were absolutely incredible. And hopefully sometime in the near future, we can get funding again for this to continue on in the upcoming years. So I know I only had 5 minutes to present, so forgive me if some of the details are a little thin, but I'm not sure if we have time for questions, but in case you think of questions for later on, feel free to always reach out to me, send me an email. I'll also drop my email in the chat for whoever's interested.
Thanks so much. That was an excellent presentation. And, we do have 3 more. So I think we'll hold off on questions for the time being, but please, if you have any questions on that one, just write it down. And if we've got time, we'll make sure to loop back.
Great. Thank you so much. Thanks, Chantal. That was awesome. My name is Melissa Temke, and I am the Behavioral Health Communications Manager for the Healthcare Authority. And my colleague is Ann Paulson, and Ann is the State Opioid Response Outreach Communication Coordinator. And we are going to just go through quickly some opioid misuse prevention and overdose prevention campaigns that the Healthcare Authority has. So go ahead and go to the next slide. So unfortunately, overdose deaths that involve opioids are a growing crisis in our state. And when we talk about opioids, we are talking about prescription medication that have opioids in them and also illicit fentanyl. So HCA is committed to promoting a healthier state. And we have created several campaigns to inform people about the risks of misusing prescription opioids, the dangers of illicit fentanyl, and how you can protect your friends and family from an overdose. Next slide, please. And so Anne is going to take us through our campaign, Friends for Life. Go ahead.
All right, thanks, Melissa. And thank you, Chantal. That was a very thorough research background. HCA followed many of the same steps as DOH, but they're not represented in these slides. We have 4 campaigns that we're going to kind of overview now, so we kept it pretty simple. But we did, when it came to Friends for Life, we had some intensive research before we started that surrounded sort of what is the general population, the youth population, what is their awareness of fentanyl, what is their understanding of fentanyl, what is their understanding of naloxone. And this helped us frame our initial steps in this campaign, which launched April 2023. Our principles were to start and end with the same people. So with that research, we found that a lot of people didn't understand naloxone, didn't understand the importance of carrying it. So we had a number of surveys and focus groups in the development of the material, and we decided that the first phase of this campaign would focus on carrying naloxone, normalizing naloxone, and bringing awareness of why it's important to carry naloxone. So a bit of a harm reduction phase. And then the second phase, which started in the summer, late summer, was more of a primary prevention focus for a slightly younger age group. So the first launch of the campaign in April was for people who use drugs 18 to 25. And then the second launch, or the second phase, was a 12 to 18 age group. So the main tenet through both phases is that everyone deserves a chance to live, full stop. That's a core value of this campaign. So like I said, we had harm reduction and prevention materials developed. We included a lot of surveys with SSPs around the state. We did focus groups. We sought feedback from the audiences that we were trying to reach. We are planning to expand this in 2024 to include some MOUD education, and one of the main focuses of the primary prevention phase for the younger group was to change the cultural norms of sharing any medication. You can see in this slide here, there's a couple images of what the campaign looks like. There's a lot of toolkit materials available on the website. And we just wanted to recently to announce that it recently won a Silver Anthem Award in the health category, which we're very proud of. The messages of this campaign, we stand by 100%. It's really important for us to share this information, and we're hoping to expand the messaging going forward. The outcomes of the first 2 phases that have already run are here on this slide. We've received many technical assistance requests from ESDs around the state, and we've heard a lot of positive success stories from using our prevention activity and our community presentations. We recently began work on fulfilling a large co-branding request from the Seattle Children's Hospital, and we've already partnered with DSHS to create material for their community service offices, mostly mirror clings, but also some wallet cards, I believe, to include recovery helpline information. So we are really excited to expand this campaign, to see it grow, to include more information under this brand umbrella, and to continue offering information across the spectrum so that we are giving honest, truthful, accurate information to youth and young adults across the state of Washington. And I'm going to pass it off to Melissa to touch on our next campaign.
Great. Thank you, Anne. And I'm just seeing in the chat from Caleb, is everybody seeing the For Our Lives slide? That's the slide that we're on. Okay. Caleb, I'm not sure what's going on. Okay. I'm not sure what's going on with your computer, but maybe you want to. Okay. That's great. Thank you. Maybe you want to try hopping off and trying to hop on again. Sometimes things can get stuck. Yeah. Teams has issues for sure. And especially the new version. I agree. So I'm going to switch gears just barely a little bit and talk about the For Our Lives campaign. The For Our Lives campaign is done in tandem with tribes across the state. The goal is to give overdose prevention information, illicit fentanyl information, to make tribes aware of naloxone, and also treatment and recovery, and also to try to destigmatize that message of substance use. For Our Lives was done with input, like I said, from tribes. And go ahead and go to the next slide. Although it is specifically focused on adults, there is proposed legislation in this year's budget that would give us funding to expand the campaign to reach out to youth and young adults. So as you can see, the campaign outcomes are on the screen, and I really just want to go through kind of some of the ones I think that are really show the success, which is that we had over 26 million impressions. We had over 50,000 visits to the website, and tribes were reaching out to get toolkit materials. We are also, with the For Our Lives campaign, going to be giving materials to every tribe in Washington state, as well as about $30,000 for that tribe to decide how that messaging and those materials are shared out for the best use of that, because as a state, we can't go into a tribe and say, this is what you should do. So we're really putting that onus on the tribe to decide the best way that they can educate their fellows. All right, go ahead and go to the next slide. All right, and Anne's going to talk about the Starts With One campaign.
Okay, so this campaign might look familiar. It's one of our oldest running campaigns. This is a campaign primarily focused on prescription opioid misuse and preventing it. So it's a prevention campaign that has a priority audience of teens and young adults, parents of caregivers, and older adults. And the main messaging tenets of this campaign are that there's one simple step, which is taking your medication back or locking up your medication. There's one honest conversation, which is as a parent talking to your kid about prescription opioid misuse. Or there's one act of courage, which is talking to your friends as a young adult about prescription misuse. We just finished a digital media buy for this young adult audience in the Starts With One campaign in the fall of 2023. And we are currently in our year 6 of this campaign. So we're planning and figuring out new material. We're updating the website and adding a bit more streamlined information onto the website. So that will be coming soon. Here are some campaign outcomes for this past year. We had a couple different media buys for the different audiences. You can see we had ads that resulted in 86 million impressions, thousands of prevention material downloads. Oh, I did want to mention, I forgot to say, all of the Friends for Life material and Starts With One is in English and Spanish. So both languages are offered, and the toolkit materials come in both languages. A big element of Starts With One is to encourage Take Back Day participation. So we provide a lot of materials for the coalitions around the state through the Community Prevention and Wellness Initiative at HCA. We're planning and working on developing more evergreen material to support communities that have take back events around the year. And we also include the pharmacy program in this campaign. It shares branding, and it's a partnership with multiple pharmacies across Washington. We do sort of a short focused run of the pharmacy program where we partner with the pharmacies, we give them material and talking points. We provide them with locking bags, which they can provide to patients when they pick up opioids. And we encourage pharmacists to have conversations about locking up opioids at home and the importance of doing so. This is I think it's the 6th time we've run the pharmacy program, and so we're just now collecting data from the last run, which ended at the end of 2023. And so I'm going to pass it back to Melissa for just the last sort of partnership.
So the last campaign that we're going to talk about is a partnership with the Washington State Hospital Association. And this particular campaign is really unique because it uses the same messaging and the same sort of look as the Starts With One campaign, but it's really its own thing. So with this campaign, we reach out to providers across the state and give them materials and training and messaging on the best way to talk to their patients about not automatically taking an opioid if they're in pain or if they have surgery, but starting somewhere lesser. So starting with ibuprofen perhaps, or starting with Tylenol, or starting with icing and heat. And if they are prescribing opioids, to really talk to their patients about how to safely take those opioids and store them. So the audience is, as I said, healthcare providers really and their patients, but it's really talking through that healthcare provider program. So go ahead and go to the next slide and I'll talk about how this campaign is shaping out. So you can see the outcomes on your screen. But basically we have over 130 hospitals and hospital systems who are taking this campaign messaging. And so we've given out 52,000 RAC cards, 52,000 wallet cards. Those are in Spanish and English. We have prescribing best practices guidelines that have been distributed to hospitals. We've had over 1,300 users who went on their own to the online toolkit, which is available on the Starts With One website. And we have 8 million impressions that were done from our paid media effort. And that effort was really focused on hospital campuses and clinics in those areas. And then we've had 215 kits of education materials that were given directly to providers, to conferences and events. And we also have what's called provider ambassadors, and they have shared out about responsible prescription practices. We have a really, I think it's a really amazing video of doctors sharing their success stories about this campaign. And that has been circulated to everybody who's a Washington State Hospital Association member. And it was also part of an op-ed that ran in the Olympian this last year. So we went through these really fast. I don't know if there's time for questions or not, but I can go ahead and put my email in the chat if you want to reach out. I think the biggest thing I want everyone on this meeting to take away is that these materials are available. You can go to the websites, you can order materials, you can use them out in your communities in the best way that you know how. And if you have additional questions, please don't feel free to reach out.
Any questions now? We got time for a couple questions.
Oh, cool.
Okay. I don't see any, but please use those links to contact Melissa or Ann. And again, thank you for all your work. Thank you for being here.
Yeah, thanks.
Yeah. Okay, next item on the list was our walk-on item. Michael, anything more on from our end on where we're at with the bill?
No, I mean, it has passed out of the House, and so I think it's just waiting signature from the President of the Senate and the Speaker of the House before it goes to the Governor's office. But it sounded like Caleb was more curious about the current status of the bill and had some comments about evidence-based practices, and it seems like it's almost at the finish line, so I'm not quite sure if there's any time to address those. Like Michael indicated, it is a DCYF-centered bill, so we can definitely have Department of Children, Youth, and Family come for a future meeting and talk about some of their efforts, either pre-legislation or post-legislation.
Okay. I'm not sure that I don't see Caleb on here. He may have to, yeah. Okay, go ahead, Malika. Thanks.
Oh, wow, you can actually see me. Okay,
I can see you now.
Okay, so I was wondering if we can have more than just DCYF's perspective on the bill. I think that it would be important to have, because there were a lot of concerns about this bill from multiple stakeholders in the community, and maybe that we invite other folks that were a part of, so the Keeping Families Together Coalition, as well as the, oh gosh, sorry, I'm not super prepared, but I feel it like it was the ABC. There was a number of people that were testifying. Vocal was very involved in this session related to 6109 because we have a lot of concerns. I mean, the bill is going to serve to stigmatize people that use drugs, and it's going to make it easier for people's kids to get taken away. And like a lot of the progress that was made with 1227 from Keeping Families Together was undone by this bill. So there's a lot of implications, and I would really hope that we could have multiple perspectives, not just what DCYF has to say.
Yeah, I mean, yeah, I think that makes sense. How about what I'll do is I'll connect with our lead analyst from DBHR and just let them know that this came up at the SURSAC meeting and there was a request for a more intentional conversation around it, and then maybe connect with you, Malika, and see if we can get some of the individuals that represent those other associations, or all they might already have that information. So let me check in with them, and then I may reach out to you and some others.
Okay, thank you.
Yeah, thank you.
Thanks, Malika. Anything else on that topic? Sounds like we have some action items for that to move it forward. That's great. Anything else? Any, I guess we have, if any public comments want to be made at this time, again, we can go ahead and take time. If you missed it at the beginning of the meeting, take time right now to take any public comments. Just please go ahead and raise your hand in the virtually there, and we will call on you. Okay, one more time for public comment. All right, don't see anybody, so Michelle, I will turn it back to you.
All right, thanks, Blake. So now we've got a full half hour really to talk about the next agenda. the primary item on the April agenda for SURSAC is going to be a review of the 2024 legislative session with a focus on any bills that either that support the SURS plan implementation in particular, and also other impacts to the behavioral health system policies, that kind of thing that may be of interest to the committee. So that's going to be our main item, and we're going to reserve the bulk of the meeting for those updates and questions and discussion. But the other item that I wanted to talk about, because this came up as a high priority item in the mentee survey back in January, is the drug paraphernalia law. And before I make any assumptions about what it is around that you want to discuss, I wanted to check in with the committee and just make sure that we were clear on what the focus of that conversation would be, since that's not something, I mean, HCA is impacted in some ways by that law, but it's not something that we are implementing ourselves. And so we don't have updates around implementation per se, but just curious about what it is around that you want to talk about, or if there's issues that you're aware of around that law that you want to bring to the discussion. But I just, right now, opening comments for clarification around how we should frame that discussion to be the best use of your time. Yeah, Malika, go ahead.
Are you referring to paragraph 2 of section 8 of 5536? Is that what you're referring to when you say paraphernalia?
So I'd have to, sorry, Emily. I'd have to go back and look at that reference that you just made to know for sure. But this was, this is referring to the recommendation that came from SURSAC to change how the drug paraphernalia law was worded. I know that change was made, but then there were other additions to the law that made it so it wasn't quite implemented in the way that SURSAC had intended. And that was added to the mentee survey in January as an item for discussion because it's part of the SURS plan. And so I just want to clarify to the group, whoever voted for discussing this, what they want to discuss about it.
I was on leave during that time, but I did do the survey, but I believe, okay, I see Sarah's comment in the chat. I can actually see the chat now. Yeah, so it was paragraph 2 of section 8 of 5536, which actually undid paragraph 1 of section 8 of 5536. And I do think that it would be good to have a conversation about that, because we are seeing local jurisdictions that are being impacted by the paragraph 2, and access to syringe exchange and mobile syringe exchange in rural areas is being impacted. So I don't know what you mean by, like, to what degree you're trying to have a conversation. Do we want to invite impacted jurisdictions to update the group, or what are you suggesting? Because we can talk about it all day long, but I think that it would be good for the group to hear about some of the local political activity that's occurring, as well as ordinances that are being developed that will impact that could potentially impact syringe exchange in rural areas.
Yeah, thanks, Malika. That's exactly what I wanted to know. So it sounds like you're saying it would be helpful to feature some local political activity that is happening around this law and its implementation, and then hearing directly from any jurisdictions that are impacted from it and how they've been impacted from it. Is that right?
Yes, and I think if you look in the chat, so Lewis County is currently having an ordinance hearing on syringe service plans to limit mobile syringe exchange in their county. So as a person that used to do both fixed site and mobile and used to serve Lewis County, people would come to Thurston County for that service. There's a lot of people that need access, and this will definitely have an impact on overdose death. It will have an impact on disease transmission. And this is all at a time when both of those things are a big deal right now. Like, it's not going well. we're not winning the battle. So
Okay.
so there's a lot of chat, right? So I think that it would be good to invite the service providers in that area, and maybe even the commissioners that are putting forth these restrictive and other representatives, so that maybe they can tell us what their thinking is, so we can better understand it, and also maybe they can have an opportunity to get educated.
All right, excellent. Yeah, thank you. That definitely helps to understand how to frame this meeting and who to invite to the table around it. Any other thoughts about that conversation for the next meeting, and what you want to hear, who you want to hear from? Yeah, Hunter, go ahead.
Yeah, I guess kind of piggybacking what Malika said about understanding their reasoning and educating them. I think that's good. And I think more importantly, if we have an opportunity to understand the reasoning to press restrictions, I think we could formulate a plan to attune to those issues, whether it's like public drug use or like littering of syringes. I'm not sure how qualified we would be in that ballpark, but I do think it would be absolutely necessary to meet the needs of those issues that are ultimately preventing some of these harm reduction plans from being implemented at a large scale. So yeah, those would be my thoughts.
Yeah. Thank you, Hunter. That's really helpful. Anyone else? Okay. Well, that was our final agenda item. So with that, I will pass it off to Michael if you have any closing comments for the group.
Yeah, a couple. I was just following up. If there are other examples of communities where this is playing out, or perhaps places where it's, met the intent or being effective either way, please let us know that. We're certainly hearing a lot about Lewis County right now, but I'm not sure we're hearing about it in other places at this point in time. We did early on, but not recently. So if you have other places you want to hear from, let us know. Other than that, yes, let's thank you all. I will give you a little gift of time back here today, but thank you for joining today. For those legislators, I know at least saw one or two on here. Thank you for your continued effort, and we wish you well in the closing days. For those that presented, it's just awesome. It's really great to hear how things are going with RNP and to get a little snapshot on the different campaigns that are happening. If you need materials, let us know. We can help get those out. But yeah, thank you all. Michelle, thank you for organizing again and all that's behind the scenes here to keep this thing. Have a great day, everybody. Take care.
Have a great week. Bye, everyone.